Okay, we are live. Over to you.
Yeah. Okay.
Good evening, sir.
Good evening.
Good evening. Good evening, sir. Good evening.
Sorry, that's people connecting. Okay, so welcome everybody to today's talk, which is going to be by Professor Ananda Kishor from Kolkata. I think all of you must know him. He is a true academic working in Institute of Postgraduate Medical Education and Research in Kolkata. So it's a great pleasure to listen to him, and he will give a talk on basics of orthosis and prosthesis, which is an important topic for the DNP students. Dr. Pal.
Thank you. Thank you. Thank you, Dr. Mukhopadhaya. So I'm here to discuss a very, very important topic, which is the basics of orthosis and prosthesis. The orthosis and prosthesis is a different world, like a third world country. See, this is a very so important. So you can fight in the territory of the army, territory of the war, where the most of the war is already owned by the enemies. So the orthosis and prosthesis, when everywhere fails, then this is the only armamentarium you have to come out from the enemy's territory. This is the orthosis and prosthesis. Is it audible? Is it audible?
Yes, sir.
Okay, so we'll continue.
Yeah, we can hear you quite well. Yeah, don't worry.
Okay, I'm continuing. So the first of all, we have to know the classification. Now the classification has become very much simplified. Basically, it is based on the universal classification, and is based on the joint which is encompassed by the orthosis. So basically, first, the what is orthosis? Basically, it is the external appliances which can enhance the lost function, which has augments, enhance the lost function of the body. As a prosthesis is basically another external or maybe internal. So basically, we'll talk about the external prosthesis. Basically, it is also an external appliances which can replace the total lost function of the body. So this is the basic difference between orthosis and prosthesis. Now classification of orthosis is based on the joint which is encompassed by the orthosis. So in the lower limb, so it may be foot orthosis, or it may be ankle foot orthosis, it may be knee orthosis, knee ankle foot orthosis, or the hip knee ankle foot orthosis. So depending on if the orthosis is encompasses only the foot joints, that is below the ankle, that is the foot orthosis. So in that sense, we are always every day we are using this foot orthosis, that is the shoe or boot. So what is the difference between the shoe or boot? The basically that is the foot orthosis which extends just above the level of the malleoli, that is the boot, and if the upper of the foot orthosis lies below the level of the malleoli, below the tip of the malleoli, that is known as the shoe. So basically, we are using every day the foot orthosis. On the other hand, if the disease is both the considering on the ankle as also the foot, so we have to extend above the ankle. So in that case, we have to orthosis of choice is the ankle foot orthosis. So if the disease is only confined to the knee, so we have to encompass the knee level only. That suppose the osteoarthrosis of the knee. So only the knee joint should be encompassed, and the orthosis of choice is the knee orthosis. Otherwise, if it is a knee, ankle, foot, both are affected, so we have to encompass all the three joints, and the orthosis of choice is the knee, ankle, foot orthosis. Similarly, hip, knee, ankle, foot orthosis. In severely paralyzed monoplegia, we can use this hip, knee, ankle, foot orthosis. For the upper limb also, if there is a disease is confined to the finger joints, it can be considered as the finger orthosis, or it may be involved with the hand component, it may be hand orthosis. If is the hand and wrist both are affected, so wrist hand orthosis, like the disease like carpal tunnel syndrome. So in that case, we can use the short walk-up splint, which can be used as a wrist hand orthosis. Or if there is some problem in the first carpometacarpal joints, as is in the First, carpometacarpal joint is the most commonly affected joints in the osteoarthrosis of the upper limb. So in that case, the orthosis of choice is the thumb wrist orthosis. So in that case, we can extend. If it is only confined the shoulder, it's the shoulder orthosis. Only elbow, it is the elbow orthosis. That means shoulder elbow orthosis, or it may be shoulder, elbow, wrist, hand orthosis. Like the example is the aeroplane splint, which is basically this shoulder. This encompasses all the joints: shoulder, elbow, wrist, hand orthosis. Similarly, the spine, the cervical collar, that encompasses only the cervical spine. So it can be called as a cervical orthosis. If it is a cervical, as also part of the dorsal region or thoracic region is involved, it is on the cervicothoracic. Then it is a lumbosacral orthosis, sacral orthosis, lumbosacral orthosis. We can go so on. So we'll come later on. So basically, what are the materials used for preparing this orthosis? It may be conventional orthosis or maybe modern orthosis. As you can see here, the conventional orthosis basically is formed by the one single or double bar. You can see here there's a cup band which is attached to the body, and there is some joints when through the joints the part is attached like the boot or shoe. You can see here. Now this is the conventional orthosis. Now this is the if you want to have some modern orthosis, because conventional orthosis is cumbersome. It is heavy, and now the new generation people, they want the light orthosis. So in that sense, this orthosis which is made of the thermoplastic material. Basically, there are two types of material by which, with the help of the heat, that can be produced, either thermostatic or the thermoplastic. But a thermoplastic material is the advantage is once after it is completely prepared, depending on the patient's need, that can be reformed or that can be changed. That is known as plasticity. That is known as thermoplasticity. So thermoplastic material is commonly used for preparation of this modern orthosis. Very lightweight. See, it's very lightweight. Same. This ankle foot orthosis, and this is both the ankle foot orthosis. It is very light. Okay. So this is the classical orthosis. Now for the foot orthosis, what are the basic requirements? We have to know the basic requirements. See, this is the walking cycle. You can see here, gait cycle is the heel strike, foot flat, mid stance, heel up and toe off. This is the stance phase, and the acceleration, mid-wing, and the deceleration. This is the swing phase. Now, basic movement is required for this. It's required. You can see here for the foot in the stance phase, plantar flexion of the ankle, and the metatarsophalangeal joint flexion during the push off. That is toe off, heel off, and toe off phase. It is most important. This is most important. And the swing phase during the ankle, you can see here, at least 10 to 15-degree dorsiflexion is mandatory. Otherwise, ground clearance will become very much affected. Now, for the knee level, knee should be very much locked during the mid stance. It is very important. Very Otherwise, it can be buckled, and there will be problem of standing and walking. And see the flexion of the knee is not very required, because it is helped by the gravity. Only the anti-gravity action is most important. So for the knee extension, knee locking in extension is important. And for the hip, the flexion, as it is anti-gravity, it is required. So this is the basic: hip flexion, knee extension and locking in extension. And for the ankle, there are three components: plantar flexion of the ankle and metatarsophalangeal flexion during the stance phase, and some degree of dorsiflexion during the swing phase. So you have to calculate this knowledge during the preparation of the orthosis. Now the orthotic components, there is the interface components I already told, which attaches the orthosis to the body. That is cup band, thigh band, like this. There are some joints in the suppose in the knee, suppose the ankle joints. There are actually 5 types of the ankle joints: free motion ankle joints, limited motion ankle joints, lock motion ankle joint. Lock means that is plantar flexion lock or foot drop stop, or it may be assisted or resisted motions like the dorsiflexion assist, maybe foot drop stop or the dorsiflexion stop, or it may be assisted or resisted means there is dorsiflexion assist, or plantar flexion assistance is usually not required because it is helped by the gravity. So these are the 5 types of joints. Now structural components I already told. For the classical, it may require some bar, it may be single bar, side bar, or the double bar, and the cosmetic component, which is only provided by the classical, the modern orthotics. Now indications, you can see here, Basically, there are 4 types of indication of the lower limb orthosis. There is maybe weakness, it may be upper motor neuron type or the lower motor neuron type. It may be loss of structural integrity caused by the trauma, like inflammation, or there is some failed operation, like failed replacements, like that. Deformity, it may be flexible deformity or the rigid deformity. Flexible deformity is another, is known as the dynamic. Suppose there is a common peroneal palsy that will lead to foot drop. That is a flexible deformity or dynamic deformity. But if that deformity is persistent for a long time, then all the structural components becomes contracted, and ultimately that will lead to the rigid or fixed deformity. So this is the basic difference. Now the hypersensible foot may require some orthosis. We'll discuss later. So weakness, loss of structural integrity, deformity, or the painful or the hypo, that is reduced sensation. Now one by one. Now unstable joints. If there's some instability, it may be unidirectional instability or the multi-directional instability. Suppose it is a ankle that's only the foot drop. There is no other function is affected. That is a unidirectional instability. The instability is only in the sciatic. If this is associated with some loss of some inversion, eversion, that means the coronal plane instability. So this is a multi-directional instability. So for the unidirectional instability, there are several treatment options are there, like tendon transfer, osteotomy, bony block, and tenodesis. If it is possible, then you offer this treatment for this. If there is no possibility of offering this, then only we have to consider for the orthotic stabilization, or orthotic stabilization can be considered for time before going to become the definitive treatment. For multidirectional instability, if it is a skeletally immature patients, orthotic stabilization is the main treatment. Whereas in the skeletally mature patients, best form of treatment is the arthrodesis. If the arthrodesis is not possible, then only the orthotic stabilization is the only treatment. So this is the algorithm. Now, if there's only foot problem, we can see here there is a collapse of the medial arch that may be due to some weakness of the inversion, medium inversion. So that will lead to a pes planus deformity. So how can it be treated? So that can be treated with the help of the medial arch support on the medial side, or is the ankle foot orthosis, rigid ankle foot orthosis, which can prevent to become which will prevent the heel to become collapsed in the valgus position, or it can be used with this lateral heel float, or there's some lateral heel float and the heel cup and the lateral heel float that can be incorporated in the foot or in the foot orthosis, that is the boot. In the boot that can be added along with this. This is very easy and cosmetic. So for the foot problem that can be used. Now for the ankle and foot weakness, suppose there is some absent dorsiflexion, that is foot drop. I already told, either foot slap or the foot drop. The absence, or there may be associated plantar flexion, or there is absent subtalar motion. So there is a multi-directional instability. So what are the options for multi-directional instability? We can use this conventional ankle foot orthosis, double bar. What are the parts? There is double bar, then the cup band and the ankle joint, which may be normal ankle joint and the foot. On the other hand, it can use the simple flow reaction orthosis or articulated flow reaction orthosis. That is a classical or modern ankle foot orthosis. I already shown what it is, with or without heel cushion and the rocker sole. What are those? I'll come. Heel cushion, basically it is attached under the heel, which will simulate the plantar flexion if it is a non-articulated FRO. Because it's a non-articulate, that means there is no ankle joint. But we have to, during walking, we want plantar flexion as also the movement of the metatarsophalangeal joint. So if it is a non-articulate, that means there is no ankle joint. So in that case, if we add some compressible rubber under the heel, that is the heel cushion, during this heel strike, that will once it is compressed, that will simulate the plantar flexion. And during this toe-up phase, once it releases, that will act as that releases the energy, and that will help in propagation, and that will help during propagation of his limb. So that is known as the heel cushion. And the rocker sole, that is, I will come. What is rocker sole? That is basically it's a elevation which is just added on the sole aspect of this non-articulated FRO, just opposite to metatarsophalangeal joint, because just rocker action, having a rocker horse, which is a common toy for the child. So during this rocking action, so once they propagate, that will help, that will simulate the movement of the tarsometatarsal joint, that is a toe-off phase. So suppose this is the real case scenario. This is we have to see how to prescribe this. Now, first we have to ask these questions. Which joint is affected in this case? So that is basically, see, this is the plano valgus foot with some dorsiflexion. You can see here. So both the ankle joint as also the subtalar joint, both are affected. You can see here, ankle as also the subtalar joint. So both the multiplanar instability, the multiplanar, there is the multiple joint involvement, multiplanar instability. See, you have to see whether it's the only the swing phase is affected or the swing and stance both are affected. So why it is important? Because if it is deformity is seen only during the swing phase, but it is corrected during the stance phase, that means it is a rigid, it is not a rigid deformity, it is a flexible deformity. Okay. So if it is only swing phase, so there is flexible deformity. If it is seen in both the phase, that is it is rigid deformity. And what are the functions lost? There is the plantar flexions lost and the inversions lost. So what are the orthosis to be offered? If it is a classical ankle foot orthosis, so both the ankle and foot both are affected. So it is the ankle foot orthosis. So it may be double bar with the ankle joint, which is a normal motion ankle joint, because it is not a paralytic case. It's a normal motion ankle joint, and there is a cup band and a boot. Or if it is a modern and modern variety of orthosis, that should be a modern variety as FRO. See, these are the modern, the thermoplastic ankle foot orthosis. See, what are the parts? This is asked in the examination. This is the posterior shell. This is the cup band. You can see here. Anterior trim line. This is the anterior trim. See, what is the difference? The anterior trim line is gradually becomes reduced. This is from this area to this area. You can see here. Now, what is the difference between this anterior trim line from this design to this design? If there is only the ankle joint is affected, so in that case, so this type of FR or the modern ankle foot orthosis is used. So these are the non-articulated. There is no articulation. So as both the malleoli, it is outside this. It is anterior to the anterior trim line. So there is no the control of the subtalar joint. But if the subtalar joint is also affected, so this type of this type of orthosis should be used, because the anterior trim extends anterior to the malleoli. So in that case, if there is instability or dysfunction of the subtalar joint, that can be easily covered. So anterior trim line, we have to see whether it is anterior to malleoli or the posterior to malleoli. So in the depending on this subtalar joint involvement. So this is non-articulated. So we have to add some heel cushion under the heel to simulate the ankle joint function, and the rocker sole under the forefoot just opposite to the metatarsalophalangeal joint to simulate the metatarsalophalangeal joint. Otherwise, we have to use this. This is articulated. This is ankle foot orthosis. So we can. There is no there is no heel cushion is required, but there is no the metatarsalophalangeal joint action. So we have to add the rocker sole in the forefoot. Okay. Now UMN lesion. UMN lesion may lead to equinus, equinovarus around the knee, generic like this. So in that case, though we can similarly either if it is we have used the classical variety or some modern variety. Now, I've already told, just recapitulating, this is non-articulating. There are different types of non-articulating ankle foot orthosis, and this is the articulating ankle foot orthosis. Then ankle motion is not substituted. It is substituted, but the metatarsalophalangeal joint function is not substituted. That is why we can add some the foot. Okay. Now, muscle weakness around the knee. So there may be abduction, adduction deformity. In that case, that's a genu verum, genu valgum deformity. In that case, simple the knee orthosis with free motion knee joint we can use, or the anterior posterior instability, that means the quadriceps paralysis. So in that case, if it is a mild, we can use the ankle foot orthosis. If it is severe, we can use the knee ankle foot orthosis, either because knee is affected. So in that case, classical variety, you have to see the knee ankle foot orthosis. Though the ankle is not affected, still the classical variety, you have to use the knee ankle foot orthosis. So it is a very, very heavy, and that's a problem. So in that case, FRO is the alternative solution. So what is FRO? How it is differs from the conventional and that is classical ankle foot orthosis. Classical modern variety of ankle foot orthosis. See, we have to understand this. So this is the normal system, normal ground reaction system. Once the patient can stand in this manner, the ground reaction system is coming in front of the knee. that normally it locks the knee joint. But if there is some quadriceps paralysis, that means there is buckling of the knee, the ground reaction force, once the body weight is coming back of the knee, ground reaction force is coming on the back of the knee, that will cause further buckling. So in that case, we have to, if you push the knee from front, so that is the only way by which we can usually lock the knee. And that is used for the FRO. You can see here FRO, where the ankle foot orthosis is almost similar to the other variety, but there is some plantar flexion. That means the foot piece and the leg piece, it is articulated with 10 to 15 degree plantar flexion. 10 to 15 degree plantar flexion. So why? Because during this walking cycle, there is a ankle is always plantar flexed. So during this walking, what is the normal? What is the first point during this stance phase is the heel strike. But if the patient uses the FRO, so instead of the heel strike, of the body which touches the ground is the toe. That is a toe strike. So because of the toe strike, so body weight is coming in front of the knee, and similarly the ground reaction forces going upwards in front of the knee. So along the and that will passes. That is as per Newton's third law. The ground reaction forces is passes in front of the knee through the bar, through the side bar of this orthosis, as there is some anterior leg connector. This anterior leg connector, and that leg connector is pushed backward, and that pushes that ground reaction forces pushes this connector backwards, that passively locks the knee joint. That is the mechanism of choice for the FRO. What is so how it is different? So just I'm coming. See, this is the classical modern variety of ankle foot orthosis, that is leg and the leg. It is basically it is kept at 90 degree. That is not plantar flexed. But here there are two differences. First difference is this junction, the foot plate and the leg plate. It is attached at 15 degree plantar flex, and there is anterior leg bar. Now classical cuffo, you can see it. So how this is the side bar. There is there's cuff band. There is anterior knee pad. There is a thigh corset. The thigh corset. You can see the thigh corset. And this thigh corset has been above in area. If there's some ischial weight bearing arrangement, that is a weight bearing cuffo. And there are some knee joint. So and at the lower part it may be ankle joint with a boot. Okay. So cuffo, you can see here. It is combined. It is cuffo. Just have described. These are the parts. This is the side bar, knee joint, ankle joint, thigh bar, thigh corset, and the thigh band and the cuff band with or without the help of the boot. Now subtypes. It may be single or double bar cuff or total contact cuff or ischial weight bearing. We have to examine the outer part of the thigh corset. If there is some rigid sitting arrangement on this, that is the ischial tuberosity sits on this, that is the ischial weight bearing cuff. This is a thing I'm not going into detail because this is just very we have to just clearly we can just overview I can discuss. You can see here this is the ischial weight bearing cuff. You can easily sit over this, and that can be modified with the help of this. This is this is basically it's a fracture bracing. If there is some delayed union or some refractory non-union of the lower part of the femur, that can be easily treated with this. This is the form of this in the form of the fracture bracing. Okay. Now this is a H cuff. See, this is the H cuff. We commonly used for the spina bifida, spinal cord injury, or it may be the LS, that is a lumbosacral H cuff. If there is associated trunk paralysis, it can use this. There are some other variety like parapodium. Parapodium is another alternative for this. I'm not going into detail. So that's just it can understand. So if there are some both the limbs are paraplegic patients, either you can use this H cuff or the LS H cuff or the parapodium. Now hip abduction orthosis. In some diseases we require some abduction. Hip should be abducted for a long time. Suppose example that the Perthes disease. So in that case, the hip should be contained inside the femoral head should be contained inside the acetabulum. So in the position of the some flexion abduction. and some internal rotation. That can be done with the help of this hip abduction orthosis. So this is the hip abduction orthosis. Now another orthosis is basically the public harness. You can see it's very important, public harness. One is the dislocation, that is a DTH variety. Another is the fracture in this in the infants, fracture of the shaft of the femur in case of infants. In that case, you can usually use this public harness. There are several parts like the chest strap, shoulder strap. There is in front there's a flexion strap, and then the back there's abduction strap. So in that case, we can maintain the hip position in the flexion, abduction, and the external rotation. So you can easily, so and depending on that the position, if you can take the radiograph in this position, that you have to see whether the hip is completely going inside the acetabulum or not. And depending on the radiograph, we can adjust the either flexion or the abduction in this manner. So this is the public harness, and that can be used for the different purposes, most commonly the DTH and also the fracture shaft of femur. Now another is this is known as the standing, walking, and sitting hip prosthesis. Standing, walking, and sitting hip orthosis is basically see both the hips are is maintained in abduction. So in that case, if it is a bilateral prosthesis, which is very rare, but there is a multiple epiphyseal dysplasia where the hip is constantly it requires to be maintained in flexion and abduction. So in that case, it is standing, walking, that is a Schwarz orthosis. Standing, walking, and sitting hip orthosis may be required for very small children. Okay. Now, impaired structural integrity in the leg. There are two types of structural integrity. It may be either non-union or gap non-union, but if in refractory cases of the gap non-union of the tibia, so that maybe is open fracture treated by several methods. Still, there is not united. Patient is now is unfit for the surgery. In that case, we have to use this. Otherwise, it's some similar thing is seen in the femur also. In that case, still the patient will be able to walk with the help of this ischial weight bearing. There is a knee ankle foot orthosis. So in that case, we have to bypass the body weight. So suppose there is some defect in the femur. In that case, body weight should be directly bypassed from ischial tuberosity to the ground. So with the help of the ischial weight relieving caliper, that is the classical the knee ankle foot orthosis. So in that case, so if there is some structural defect of the tibia, in that case we can use the patellar tendon bearing orthosis. Patellar tendon bearing orthosis. So in that case, the body weight from the femoral condyles and the tibial condyles is directly coming to the ground, bypassing the tibia with the help of this. Okay, and see the solid ankle foot orthosis. Basically, this is the orthosis. This is the patellar tendon bearing ankle foot orthosis. And this anterior shell is the posterior shell. This anterior shell is just it is molded. It is made of the thermoplastic. It is molded similar to the patellar tendon bearing PTB plaster, as we molded on the side of the patellar tendon. There is a ligamentum patelli, and also the molding also against the tibial condyles, tibial condyle. And this is a posterior shell which will bear weight on this, and there is some strap. So this is a patellar tendon bearing ankle foot orthosis, and for the femur we can use the ischial weight relieving caliper. Now, unweighting ankle foot orthosis is the patellar tendon bearing or non-patellar tendon bearing may be there. So in that case, we can use bypassing the weight, suppose for the fractured tibia. So similar, this type of splints are there. We can use this is a crow walker, cam walker, ankle foot orthosis for the fracture management of the lower limb. So fracture distal part of the tibia, we can use this. Okay. Now for the steep foot and ankle. So what are the abnormalities? Initial foot contact. See, this ankle is completely steep. This equinus deformity. Ankle is completely steep. So initial foot contact, instead of the toe, heel strike, there is a toe strike. So we have to build up the heel. Build up this. Okay. Next, plantar pressure distribution is absolutely abnormal. So you have to equally distribute the pressure throughout the sole. So how can it be done? So that can be done with this building the sole of the foot like this. The total contact, so which is meticulously contact should be designed with this. This is the sole, and the ankle motion is simulated with the help of this heel cushion. See, this is small. This made of the rubber, and this is rocker action. Rocker action which simulate the toe off. So that in that case, patient will easily able to walk with uniform pressure distribution there is full contact of the sole, and there is a simulate the ankle motion as also the metatarsophalangeal joint, that is the toe of face. Now, this is the say this is the if it is also coronal plane deformity. Similarly, this type of waging should be done on the sole, which so that whole sole, however it is deformed, whole sole should have the equal pressure distribution in all areas. So there is no pressure in pressure concentration. Now, you see, this same type of principle is used for the insensible foot. So, insensitive, what are the other problems? The uneven distribution of the pressure over the insensitive skin that will lead to pressure ulcer. Skin can be easily damaged from external injury. Unhealthy skin is very dry, so easily damaged. Clottos should not be pressurized, should require extra room and excessive energy required for the walking. So this is the this type of pressure measurement can be done. There are some special instrument, and with this special instrument, we can easily measure the how much areas are you have to spread from which type of which area, and these are the areas where maximum pressure concentration is occurring. So total contact sole should be prepared, and insensible foot, the metatarsal support and the sole should be very much stiff, so that the foot pressure should not be should be distributed in all areas of the foot. So this is the basically the components of the insensible foot. It should be tough outer covering, so there is no external injury will damage the skin of the foot. There is extra depth will accommodate the clottos, sole stiffener. There's total contact molded in sole will distribute the pressure. Cushioned heel simulate the ankle motion. Rocker insole simulate the metatarsophalangeal joint motion. And the areas and the under surface of the foot should be dry, hygienic, well ventilated. There are some porous, so that the skin will become very much healthy. So these are I'm not going into detail. I'm not just painful foot. I'm going to the painful foot. So if there's some painful on the forefoot, we can use the metatarsal bar or the rocker sole. What is the difference between this? Metatarsal bar, basically these are the elevations. Elevations are attached on the sole of the boot. You can see here, because the head of the metatarsal not in a same and a straight line, it is an oblique line. It is 15 to 20 degree oblique line from this coronal plane. So the metatarsal bar, this elevation should be attached against the head of the metatarsal in this plane. Whereas the rocker sole, it may be forefoot rocker, a hind foot rocker, the whole sole may be rocker. You can see the whole, there is a forefoot, mid foot rocker. And basically the apex of this rocker should be at this opposite to the head of the metacarpal, or there is some metatarsophalangeal joint. And see how to differentiate this metatarsal bar from this rocker. See the metatarsal bar, basically this this anterior edge is sharp. It is suddenly halted here, whereas in the rocker it should be rounded. It is rounded, and so it is a metatarsal bar. This is a metatarsal bar. So it is just suddenly stops at the area just opposite to the area of the metatarsal bar, whereas in the rocker action, see the rocker action is rounded, and the apex should be just opposite to the painful area, so that during this rocker action no pressure is borne by this area. So by this means the painful area can be easily bypassed. Similar thing, you can use the University of California Biomechanics Laboratory, UCBL, that is silicone heel. It may be only used opposite to the heel, or the total contact silicone hold. So that can be only used for the painful heel. If the whole sole of the foot is painful, that can be used. And this complete this nomenclature is usually asked in the examination. UCBL. What is the full form of UCBL? Now, this is a top toe during the volleyball player. This is basically that involved for this top toe. There is very severe painful metatarsophalangeal joint. So in that case, top toe plates may be attached along with the sole of the foot, and that will protect this metatarsophalangeal joint. This top toe plates is made of the carbon graphite, which may be molded as the area of the metatarsophalangeal joint, that will prevent any pressure from the ground reaction force to be transferred to the metatarsophalangeal joint. Another is there's a device which is usually for the flat foot. Usually flat foot may be congenital when the very young child usually comes with this. So in that case, so the medial arch is very low or maybe absent. In that case, we have to stiffen the medial arch. We have to stiffen the medial arch. This is the heel breast. Normally, see the heel breast, and the heel breast is extended up to the base of the first metatarsal or the head of the metatarsal. So in that case, the medial arch is very much stiffened enough. So in that case, the body will try to develop the medial arch, and that is the basis, the active form of treatment form of the treatment of the flat foot for the young patients. For the older patient, that will not help in active development, but that will help in the support of the medial arch. That is a passive one. But for the active one, active treatment for this is known as the Thomas extended and crooked heel. The heel breast is extended up to the base or the head of the first metatarsal to stiffen the medial arch, so that the body will try to develop this medial arch. This is active form of treatment of the face planus. Now the CTEV basically is the foot abduction orthosis. There are several designs of foot abduction orthosis. Basically, it is a steam back brace, which is how it differs from the Dennis Brown's print. See, the bars are it is molded. It is convex enough. You can see here it is convex, so that both the foot is everted, and both the foot is actually rotated 60 degree, 60 to 70 degree abduction, 60 to 70 degree abduction. If the bilateral cases. If it is the unilateral case, suppose the right side is normal and the left side is only involved. So in that case, left side should be abducted 70 degree and the right side should be rotated at least 40 to 45 degree. So so that the posterior point, the distance between the posterior point of the heel of this whole abducted foot should be equal to the width of the shoulder. This is the most important. So you have to correct it. So for unilateral, bilateral, what is the difference between Dennis Brown? Dennis Brown, there is no the sprint, that the sidebar is not bent, and there's only 40 to 45 degree abduction is possible. But here it is 70 to 80 degree abduction possible. It is bent enough, and the distance between this posterior point of the heel, once it is bent, is rotated, that should be equal to the width of the shoulder. This is the basic difference between the foot abduction orthosis and the Dennis Brown. Now, what are the advices usually given? This is all of you know, it is written in the Ponseti's technique. Now, CTV orthosis, it may be CTV boot, or it may be sometimes is some students tell it is a CTV shoe, but it is completely wrong. CTV is always, because it is ankle, foot and ankle both are involved. So we have to use the boot, not the CTV shoe. It is boot. Otherwise, you have to use the ankle foot orthosis like this. Ankle foot orthosis. So boot, what are the criteria of the CTV boot? This is asked in the examination. It should be no heel, open toe box, straight medial border, lateral heel should be raised by 5 mm, medial arch support, and the window at the back of the heel is most important, because we have to once the child wear the boot, we have to try to push one finger under the heel through this window. We have to see even inside the boot that there's a possibility of ankle equinus deformity. So we have to see whether the heel is completely touching the heel is completely touching of the upper part of the sole of the boot. So this is the window will allow this. So these are the actually the criteria of the CTV boot. Otherwise, CTV orthosis may be conventional orthosis, the ankle foot orthosis with single bar with T-strap, or the double bars with boot and normal ankle joint. Otherwise, it may be modern and there is thermoplastic ankle foot orthosis with anterior trim line anterior to medial line. Now, walking aids. There are several walking aids. I'm not going into detail. These are the questions usually asked, like what now, what are the types of the walking aids? What are the factors which is required for these for a good function? What are the indications? What are the muscles required for the walking aids? What are the types of crutch gait? Orthopedic crutch gait. Basically, we are concerned about this. It's either non-weight bearing, toe touch weight bearing, or the partial weight bearing. What do we mean by that? I'm going to just discuss this. This is the walker. I'm not going into detail. There are different types of crutches: axillary crutch, lobster crutch, elbow extension crutch, and this is the axillary normal crutch. Now, how will you measure the length of the crutch? This is really asked in the examination. So when the patient is standing with the crutches, both the crutches on this under the axilla, at least 1.5 to 2 inches, that is 2 finger breadth, should be passed between this below the anterior level of the axilla and the armpit or the axillary pad. And now hand grip, the elbow should be at least 30 degree flexed and the wrist should be 15 degree dorsiflexed. So in this manner, once the patient stands on this, so this is the length from this, that is anterior axillary fold to the point which is 6 inches in front and 6 inches outside from the little toes. Little, even is a barefooted little toes. Now this is the distance, is basically the distance of the crutch. Now there's a several modern shape of crutches is available, where the crutches height can be easily adjusted. But the ones the patient will stand with his crutches both on both the side of the chest wall, and that is end should be 6 inches in front and 6 inches lateral to the tip of the lateral little toes. So in that case, at least 2 fingers should pass from the axillary pad and the anterior axillary fold. This is the basically the test by which you know whether the crutch height is normal. Now there are the different types of crutch gate. I'm not going into detail. We are concerned about 3-point crutch gate because this is the 3-point crutch gate. Is the basically is a non-weight bearing, toe touch weight bearing, or the partial weight bearing will allow. For paraparesis without ground stability or the trunk control, swing to gate should be used. Whether it is a sound stability and trunk control, swing through gate. Basically, these are related with the general that is medicine patients. So not for the orthopedic patients. So it is not very important for orthopedic students also. Each limb weak or painful, both the limb, if it is weak or painful, so either it should have 4-point scratch gate, that is very much unsteady like the dogs, or there's if the pain is reduced, then it's a 2-point scratch gate. So if it is both the paraparesis or both the limbs weak or painful, so these are basically not the non-orthopedic scratch gate, but the orthopedic scratch gate is basically the one limb weak. That means either the traumatic or maybe some operation is done, like the total hip replacement is done. So in that case, so one limb weak or painful, there is a 3-point crutch gate. Now we have to know what is 3-point crutch gate. So just I have told is I'm coming. So 3-point crutch gate. So what is that? So the patient will stand like this. This is a tripod action. This is known as the tripod. That is, patient will stand with this is the right this limb, the red boot is the normal. This is normal, and both the crutch gate. This is like the tripod. This is a very stable situation. On this the blue boot, this part is the abnormal. So in that case, so once the patient will stand like this and will start the move. Start the move means he just migrate. He will bring this both the crutches in front, and both the crutches in front from the side. Okay, and next, this is the first step. Bring both the crutches in front. Second step, bring the affected limb in front, and third step, bring the giving pressure on this hand, and also this squeezing the top of the crutches between the chest and the upper arm. Then bring the normal limb in front of the crutches. So first move, movement of the crutch. Second move, movement of the affected limb. Third move, movement of the unaffected or the normal limb. So the first is the 3-point crutch gate. First move is the crutch. Second point is the affected limb. It may be the affected limb may be kept above the ground. That is a completely non-weight bearing. If they just toe touch walking, toe touch means just during this move, the second move, that is the movement of the affected limb. Just he touches the ground. That means maximum 4 kg body weight. 4 kg. I actually instruct my patients to keep some weight machines under this. Once he learns walking like this, there's toe touch walking. So he will understand that 4 kg means how much pressure to be exerted on this ground. So by just keeping some weight machine, and he can easily understand how much pressure to be given on this ground. So this is the only 4 kg is just toe touch walking, or 50% of the body weight may be exerted on this second move. That is the movement of the affected limb. That is the partial weight bearing. Again, I am repeating, there are 3-point crutch gate. First, patient will stand both the crutches by the side. First move is the movement of the crutch. First move. Second move, movement of the affected limb. Third move is the movement of the sound limb, keeping the pressure, squeezing the crutch between the arm and the chest. So this is the 3-point crutch gate, is orthopedic gate. Another is the cane. So I already told, either it should be the crutch or the crane. Elbow should be at least 30 degree flex, and the wrist should be 15 degree 15-degree dorsiflexed. So if it is more than 30-degree flex, it is too long. If it is less than 30-degree, that means it's too short. So this is most important. The cane walking. Cane walking means the patient will stand on this. Suppose this is the affected limb, this is the normal limb. We always ask the patient to use the cane on the sound side. Suppose the right side is that the totally preplantary is done, and we advise the patient to use the cane on the opposite side. So we'll start with this affected limb and the cane first, then the sound limb. So this is the cane walking. Affected limb and the cane first, followed by the sound limb. So how will you know the height of the cane is ideal for the patient? Normally, if we count the height of the body height of the patient, we make it half. That is the actually the cane height. Or the height of the cane can be easily ascertained from the ground level to the wrist joint level. So basically, how it cane walking helps. Basically, once we suppose this side is affected, this total hip replacement is done, and using this cane on that side, the cane actually basically that shares the effective load of the body, so the joint reaction force is reduced. Another important, so because of this upward force, so less amount of abduction force is required on the other side. So that will reduce the joint reaction force. So this is the basically effect of the cane walking. Now the spinal orthosis. Nomenclature is easy. There is cervical orthosis, cervical thoracic orthosis, I already told. If it is sacral lesion, we have to use the sacral orthosis. Any lesion from lumbosacral junction up to the L2, that is lumbosacral orthosis. Any lesion from L2 to D6, we have to use the dorsolumbosacral orthosis. And above D6, we have to use the cervico-dorsolumbosacral orthosis. In sacral lesion, is usually the belt. Most of the similarly, we use in daily basis the belt is basically the sacral orthosis. But at least for becoming orthosis, the width of the belt should be at least 2 inches. So there are 2 inches or 3 inches actually. For the L2, for the disease from L5S1 to L2, the upper part of the orthosis should reach up to the lower dorsal region. So there is a dorsolumbar or that is a lumbosacral orthosis. For any disease from L2 to D6, the upper limit of the orthosis should reach up to the D3, that is the spinous process of the scapula. So that is the long talus brace. I will come. There is a dorsolumbosacral orthosis. Or if it is above D6, suppose there is that is cervico-dorsal junction. So in that case, we have to use the cervico-dorsolumbosacral orthosis. What are the types? It may be flexible, semi-rigid, rigid, or it may be static or dynamic. So indications, basically, you remember these three. There's trauma, tumor, tuberculosis, means any infective lesions. Trauma, tumor, and tuberculosis. Easy for remembering during the examination. Now, functions. How it functions? It can resist, it can limit, or it can eliminate the motions, or by the 3-point fixation, or by increasing the intra-abdominal pressure for the dorsolumbosacral orthosis. So collars, you can see here, these are the collars. Basically, that can remind the patient to not to move. This is basically semi-rigid. This is a Philadelphia collar with a small hole. What is the purpose of this hole? Because there is a for respiration. Suppose this is basically it is used for the post-operative patients. So operation is done and during the mobilization this is used. And suppose it is a tracheostomy tube is used for this. Tracheostomy tube maybe coming out from this. So this is the flexible, it's a rigid type of cervical collar. But this is a cervico-dorsal orthosis. It comes from cervical region to dorsal region. So any disease of the cervico-dorsal junction that can be used. Basically, the collars and the poster, these are the posters, and this is the halo. This is a very rigid. This is a very this is flexible. This is the semi-rigid. You can see that these are very rigid orthosis. So how it helps, how it works? That usually they restrict. They remind the patient not to move the joint. Basically, it acts only on the lower cervical region. They have no control on the upper cervical region. So basically, in the lower cervical region, usually that reduces the motion. They can limit the motion. But this rigid orthosis, they can eliminate the motion. They can eliminate. This is the halo orthosis. The one with the pins are inserted from the outer level of the skull. They can eliminate the motion. So these are the basically the cervical orthosis. Now this is the rigid frame of orthosis. Now the scoliosis. Now what are the principles? 0 to 30 degree of scoliosis can be treated with signs of progression, and 32 that can be conservative treatment. 30 to 45 degree orthotic intervention. If the angle, this Cobb's angle is more than 45 degree, surgical intervention is used. So there are several types of cervical orthosis. There are dynamic orthosis, or Milwaukee orthosis, and Boston orthosis. I'm now coming into detail. Now, Boston is the underarm orthosis. Basically, it's the underarm orthosis. It is molded underarm orthosis. Basically, just after the operation, that can be used for the temporary, but it cannot be used for the long period because that is very cumbersome and is not compliance is not very good. So this is the Boston that can be easily used underarm. There is not any dorsolumbar junction, any disease of the dorsolumbar junction that can be used on this. So cervical thoracolumbocervical orthosis. This is the Milwaukee orthosis. You can see here. They basically here there's a rigid frame design. Is a dynamic orthosis. If you allow the patient to use this, there is a gradually there is a possibility of correction, and so that in that case we have to advise to wear this 23 hours a day. 23 hours a day. So use a 3-point pressure or kinesthetic reminders. You can see here there are 2 rings in the pelvic ring and the cervical ring. I'm coming into detail. Basically, what are the parts? There are 2 rings. There is cervical and the pelvic ring. 3 uprights. 1 uprights in front, 2 uprights behind, and the 4 pads: mandibular pad, occipital pad, axillary pad, and the thoracic pad. So 2 rings, 3 uprights, and 4 pads. So basically, this is a dynamic cervical thoracolumbocervical orthosis. So thoracolumbocervical orthosis. Now, what is the problem of the Milwaukee brace? Because it is very cumbersome. During we can advise to use this for 23 hours a day, but it is very difficult during the lying down. So in that case, this type of this low profile thoracolumbocervical orthosis can be used. So once it is going to become corrected for long time, once it is corrected, then only we can advise this. This is a low profile dorsolumbocervical orthosis for scoliosis. The semi-rigid design, not going into detail. This is the thoracolumbocervical orthosis. You can see here. So if there is any disease from L2 to D6 level, we have to go up to the D3 level, up to the scapular spine. This is the shoulder pad. This is chest strap, and this is the abdominal corset. That the very rigid variety, the dorsolumbocervical orthosis, that can easily correct. Suppose there is a osteoporotic, there is a rounded kyphosis because of the multiple osteoporotic wedging vertebra, that can be easily corrected with this. Lumbocervical orthosis. So you can see here this lumbocervical orthosis. This is very semi-rigid variety. It may be belt or corset, depending on how much stiffener can be used on the back. If the stiffeners can be used, that can be used as a belt. Otherwise, it may be used as a corset. Whereas it is a rigid orthosis. It is a chair back brace or night brace. There's a rigid bar, not only the posterior side, but also the lateral side. That will limit the forward flexion as also the backward flexion. The upper limit should be as a dorsolumbocervical orthosis that will reach up to the lower dorsal region, and the lower part. This is usually asked in the examination. Lower part, how much it will extend. For the female, that will reach up to the whole of the buttock. Whole of the buttock is will be covered. For the male, that should be covered half of the buttock. Because if we cover the whole of the buttock in case of male, that will cause a rounded contour, which is not very cosmetic. Okay. Now, upper limb orthosis, it is a hand orthosis, that is a wrist hand orthosis, elbow orthosis. You can see here. Basically, indications all are P: pain, puffiness, paralysis, passive mobilization of the finger for the stiffness. Main objective of the upper limb orthosis is reposition of the affected joint from attitude of deformity to position of function, and to maintain the joint mobility, reducing the adhesion. And now the modular system has come. Now, static orthosis. What are the function of the static orthosis? Pain relief, supportive. It is both. It is a pain relief. Dynamic orthosis also causes the pain relief. It is also supportive. It supports to relieve the pain. But it also if it is a deformity, then it can correct the deformity. Suppose it is a wrist drop due to radial palsy. Dynamic orthosis is the orthosis of choice. How it helps for correction, I will come later on. Now, static orthosis, there is no effect on joint motions, but the dynamic orthosis that can improve the joint motions. Now, the static orthosis cannot resist the undesirable motions, whereas the dynamic orthosis can resist the undesirable motions. Now, static orthosis, what is the disadvantage? Muscle atrophy that can cause, if you use it for prolonged period, that will cause muscle atrophy, that will cause stiffness and also dependency, which is seen in case of dynamic orthosis. Now, these are the static orthosis. Basically, the static orthosis, there are 3 types. See, this is a cocker splint. This is a static variety or dynamic variety. In static cocker splint, there are 3 varieties. Short cocker splint. You can see these are the short cocker splint. Long cocker splint. Basically, it is used for the tendon injury. The short cocker splint can be used for the any painful condition of the wrist, like the carpal tunnel. But if it is a radial nerve palsy, so in that case, this intermediate, the short long coca variety, whereas the distal limit should extend beyond the metacarpophalangeal joint, but just proximal to the PIP joints, so that we have to include the metacarpophalangeal joint, because the extensor digitorum, which is a component of the, which is supplied by the posterior basically they act on this metacarpophalangeal joint. So in that case, not the short variety or the long variety is useful. We are only the long short variety. But for the best splint for the radial palsy, it is a dynamic variety. How it corrects? Because there is a law of reciprocal innervation. That means, so once the agonist function, the antagonist will relax. Unless the antagonist relax, agonist cannot function. That means there are both are active process, and the electrical stimulus of the agonist that will come to the antagonist to stimulate that antagonist. This is the law of reciprocal innervation. So in that case, say as the finger extensors are paralyzed, but the flexures are normal. So in that case, if we allow the patient to flex it, that electrical stimulus goes on the other side to stimulate the paralyzed extensor. So that is why that can stimulate, that can try to correct the paralysis. So in that sense, it is a corrective orthosis. And so these are both are dynamic cocker splint. But how it is differentiated? Because this is acting on the metacarpophalangeal as also the finger joints extension. But here only the wrist. See, the metacarpophalangeal joint is extended. It is not affected, but only the wrist. So there is the wrist extensors paralyzed. So in that case, we can use this. If the wrist extensors, also the finger extensors also paralyzed, in this type of cocker splint should be dynamic cocker splint should be used. Now this is the knuckle bender splint. So you can see here in ulnar palsy, basic function. This is the claw hand. What is the basic functional deficit of the claw hand? That is the metacarpophalangeal joint extension. It is not flexion is not possible. So metacarpophalangeal joint flexion can be done with the help of this knuckle bender splint. So this is the thumb wrist orthosis, the opponent's splint. This will maintain the functional position of the thumb. Any painful condition in the base of the thumb, like the osteoarthrosis of the carpometacarpal joint, can use this. Now this is very familiar. This is the lateral epicondylitis press, elbow sleeve. This is commonly used for the tennis elbow. Not going into detail. This is any suppose the open reduction internal fixation is done for the distal humerus fracture. This is the elbow. This is a mobile elbow. The elbow orthosis can be used, or it can include this either only elbow orthosis or the elbow wrist that can be incorporated with this. Now this is very common splint is usually used for the shoulder immobilizer. So that can be used for the dislocation after any painful condition of the shoulder. You can use this. And this is the aeroplane splint. This is the wrist, this is the shoulder, elbow, wrist, hand orthosis. So the basic indication is suppose there is a non-union of the fracture of the shaft of the humerus. Even a hefty patient after open reduction internal fixation, we can use this to reduce the bending momentum, bending and rotational momentum on this. Now prosthesis, we have to, what are the questions asked for the prosthesis? So we have to identify, we have to prosthesis, have to nomenclature, that depends on the bone. So if it may be a transtibial prosthesis, that means if it is a below knee amputation is done, it is a transtibial prosthesis. If it is above knee amputation is done, that is a transfemoral prosthesis. Now we have to know the parts and function, how to check it. There are three components. Prosthesis should be checked before donning. Prosthesis should be checked in situ. That is in situ, how the patient has stand, can sit, can walk like this. We have to see the gait. And just after removal of the prosthesis, we have to see, just after doffing, we have to see whether the parts of the patient that where it is attached, it is healthy or not, and the limitation and recent advances. Now, prosthesis, artificial limbs, upper limb prosthesis or the lower limb prosthesis. I already told it may be transfemoral, transtibial. There are basically what are the parts? It may be socket, it is a pylon or the foot. Socket, it is techniques of the socket fabrication that can divide into lamination technique or the seam draping technique. So seam draping technique basically is a thermoplastic technique. It's a modern variety. I already told. This is very light and the compliance is very good. On the other hand, lamination technique for the very hefty patient that can use that with the help of the glass fiber, carbon fiber, which is very light, is almost equivalent to the thermoplastic variety and other optional material. Now, what are the components? You can see transfemoral. It's a comfortable, well-aligned socket. You can see here. We have to identify. See, this is for the right side. Why? How do you know this? The anterior and the lateral edges of the socket should be at least 5 centimeters higher than the posterior edge, because for its well stability. This is one. Next is the suspension system. Suspension system should be added with this. Now, then there are some rotator. Rotator is the area where the shock absorption is done. Now the knee joint should be there. Then there's the pylon. Pylon is basically the central stem of the prosthesis, and the foot. There's a prosthetic foot. Now the another important is the Kena fibers is now used. This is a modern modification. This is a recent advance. This Kena fibers, it is a herbal product. This is from the special the herbal tree that can from these Kena fibers are produced, whose polymer is almost equivalent to the thermoplastic variety. It is very light, but it is very durable. That can be used for preparation for this socket. Now for the transtibial, you can see the silicon suspension sleeve, soft inner socket, carbon definitive socket, the subtle lock, lamination adapter. There is a pylon and the prosthetic foot. This is basically a component. So these are the suspension system you can see here with the help of the TAS belt or the silation belt. Silation belt, you can use that. Use this. You have to identify this. Now, and these are usually attached at least 6 millimeter above and 6 millimeter posterior to the greater trochanter. So once we have to ask to check this, we have to check every parts from the outside or inwards. So we have to we have to see the edges. We have to see the trochanteric the area where the trochanteric ischial trochanter, where ischial tuberosity will rest on this, and on the inner side also there should not be any sharp ridges out inside that socket. So you have to check the pressure areas. Once it is doffed out, it is taken out, you have to see the pressure areas of the body. Or you have to see the adductors, scarpus triangle, and the gluteal crease. You have to see the bonding sensation of the hamstring area for the transtibial cases. And we have to see the redness and edema. Once you taken out, once after use, once the prosthesis is taken out, we have to immediately after the removal of the prosthesis, we have to see the redness and edema of the affected area. But that should not last for a long time. After some 10-15 minutes, that should usually fades away. If it does not disappear, that means there is an excessive pressure inside the socket. We have to correct it. Now, what are the points to be checked once the patient will sits with the prosthesis? Ask the patient to touch the foot to see the socket whether it is coming out or not. This is very, if the socket is, once the patient is sits and lean forward to touch the foot and socket is coming out, that means socket is very loose. So in that case, you have to adjust the socket. For the transtibial, if the patient can, whether you have to see whether patient can flex his knee or not. If it is not possible, that means that the posterior popliteal beam is going too far to impinge on the hamstring. So you have to correct it. For the transfemoral, you have to see whether the hip flexion is possible or not. If there is anterior superior beam is very high, so in that case, that will limit the hip flexion. You have to correct it. So in standing, you have to see once the patient stands, the basic distance between these two heels should be at least 6 feet. Keeping the 6 feet distance, whether the patient can stand with or without help of the support, keeping full weight on the prosthetic limb or not. So in that case, we have to see whether the knee level should be stable or not. We have to see the ischial tuberosity and the anterior superior iliac spine. If there is it should be anterior, both the anterior superior iliac spine should be at the same level. If it is not same level, that means the height should be adjusted. And also you have to see the scoliosis. If there's a limb length discrepancy, there will be development of the scoliosis, and that is a secondary scoliosis. And this secondary scoliosis is readily disappeared once the patient asked to sit down. So this is the points to be checked when the patient will stand with the prosthesis on. And due to walking, we have to see whether the dynamic fit and alignment of the prosthesis during the walking. And ask the patient whether the patient is feeling pain, that is antalgic or any discomfort during walking. And you have to see, obviously, to the pistoning. What is the excessive pistoning is developed? Pistoning means there is to and from movement at the junctions of the prosthesis, at the rotator level. That means socket is going up and down. When in the swing phase, socket is going down, and in this stance phase, socket is going up, going up. It is excessive pistoning. You have to see. Now the prosthetic, there are basically 3 points. That is early stance, mid stance, and late stance. I'm not going into detail. There are several points to be checked on this, and depending on this, we have to correct this. Now, the most important, this is usually asked in the examination, the boot, prosthetic boot. So what are the classification? Basically, the conventional feet, that is a such foot, and the Jaipur foot. This is the conventional foot. This is the actually Jaipur. All of you know, this is the Indian foods contributed for the world, and this is the Jaipur foot. This is a modern variety of the Jaipur foot. This is such foot. This such foot's total actual name is the solid ankle cushion orthosis, and this heel is basically, it is made of this solid one, and that is why it is very uncomfortable for walking in the uneven surface. And Professor P.K. Shetty, these designed this Jaipur foot, and this whole foot is produced with the three component of the microcellular rubber. There's a heel component, there is a midfoot, forefoot component, and also the toes component. It is further modified in the madras. Is the madras foot, and the whole three component of the rubber, it is tied with the vulcanized rubber, which is almost equivalent to the rubber used for the tire of the wheel of the car. And because of the rubber used on this, that because of this compression, that will simulate the ankle motion as also the subtle motions during walking on the uneven surface. These are the conventional foot orthosis. Now, the several modification has been done. That is the ESR feet. ESR is the energy storing and returning foot. That will be early ESR, energy storing. That means during this pressure on the ground, energy is stored on the heel. Once during the heel off phase, the energy is released. That will help in propagation. That is the basis of this energy storing and returning foot. It may be early ESR, it may be advanced ESR, or articulated ESR, almost a modular variety, that depending on the body weight and the constitution, that can be changed on this. And the most important is the bionic foot. This is the most advanced foot. Basically, this is bionic foot is a stabilizing variety on the propulsive variety. These are basically that will maintain that is almost the normal gait cycle is simulated on this bionic foot. So basically, energy storing and returning, this articulated ESR feet typically makes use of the electronics as small servometers to engage or the disengage component of the locking mechanism. But there's the most important is the most advanced foot is the bionic foot. It is defined as the mechanical device with one or more active components used either for the stabilization of the foot or to provide the active push-up properties. The propulsive bionic foot that is owned by the individual with a transtibial amputation. This is almost normal gait cycle is simulated. So basically, this is the gait of choice. Thank you. So now I'm love to answer by the questions for the any students.
Yeah, I think thank you very much, Professor Paul. That was a lot of information. I'm sure the students will need to digest it, and I'm sure there must be a lot of questions. So I think the DNB students should be asking their questions now. Okay.
Yes. DNBs, if you have any, please ask. Sir, I want to ask regarding one confusion usually I have. Sometimes in the examination, in theory, they ask patellar tendon bearing orthosis. Sometimes they ask prosthesis. So that is confusing during exam. So please explain regarding that.
Yeah, I understand your point. So first of all, what is the orthosis and prosthesis? It's just different. Orthosis is basically the limb is completely present, but their functions are lost. We are enhancing the function of the limb, which is already existing. So that is if the limb is existing, that is basically is orthosis. But if the limb is all completely amputated, that means if anything is required, that is the prosthesis. It's very easy. So if that was say I already showed what is the below it's transtibial orthosis, transtibial prosthesis, and also the PTB orthosis. Okay, in PTB orthosis only there are some cells, so there must be some cells should be applied on the affected limb. So that should be a PTB orthosis. That cannot be a prosthesis. But prosthesis, that should, I already told, it should be a socket, it should be a rotator, it may be knee joint, it may be pylon. Along in the pylon, there will be some cosmetic component that will almost looking like the normal limb of the patient. So that is a prosthesis. That is easy.
So when do you use a patellar tendon bearing prosthesis? Would it be because when the stump is very short, or where would you use that?
Yeah, patellar tendon bearing prosthesis is basically it is a transtibial prosthesis. The transtibial prosthesis, if we use this patellar tendon bearing, that means if the stump is very short, that means the stump, ideal stump length, it should be 5.5 inches. If it is less than that, it should, if it is less than 3 inches, that is almost equivalent to knee disarticulation. So it should not be there. So in that case, we can use this patellar tendon bearing orthosis if it is not ideal enough stump length of the below knee amputation.
Yeah. Good. So, sir, there was some other question there?
Yes, sir. Sir, how to prescribe the prosthesis, like nomenclature?
No, there was a question on chat from somebody.
Yeah.
Difference between Kleinert and Durand traction.
Difference between?
Kleinert and Durand traction. Who's that question from?
Kleinert and Durand traction.
Sir, it's from me, sir.
Yeah.
Okay,
Who's
but the
me?
traction is not the topic of this day, actually, isn't it? So if you ask regarding the orthosis process, we can ask. Otherwise, we can go for the traction. That is a very huge difference between this.
Okay, sir. Sir, regarding this one, sir, how to prescribe a prosthesis? Usually during the exam years, how to prescribe it, sir?
How to prescribe the orthosis? Yes, that is very important. That is very important question. First of all, we have to see what is the indication. I've already told. If it is a weakness, it may be stiffness, or it may be this very painful condition, or it may be due to some loss of structural integrity. So if the structural integrity cannot be treated at all with the help of the surgery or by the any conservative treatment, pain is not relieved at all. So in that case, we have to go for the orthosis. First is the indication. Next one is which bone is involved, which bone or joint is involved. Suppose for the foot. So if the pain is confined to the heel, or pain is confined to the forefoot, or it may be some joint is involved, or suppose there is some equinus deformity. So either which bone is involved or it may be joint is involved. First is the indication. Next, anatomical part, if the bone or joint is involved. Suppose it is a forefoot pain, so you can use the rocker action under the sole. It's very easy. Suppose it's a gout, which is very common for the pain in the ball of the great toe. So apart from all the medications and also any other treatment, conservative treatment, physiotherapeutic treatment, if you use some this rocker action, rocker sole, forefoot rocker, the patient will walk without any movement of the metatarsophalangeal joint. So in that case, pain will be relieved. Okay. So this is the one. Third one, if it is a deformity may be flexible deformity, it may be rigid deformity. If it is a flexible deformity, so in that, suppose it's a foot drop deformity. So in that case, we can use the foot drop splint, or if it's an ankle foot orthosis with ankle joint with foot drop stop, or we can use the ankle foot orthosis, double bar, that is ankle joint, normal motion ankle joint, boot with ankle or ankle joint should be foot drop stop with dorsiflexion assist. Because I already told, because during walking we require some plantar flexion, but 15-degree dorsiflexion is also required. So in that case, we can use this. Okay. So first of all, you have to see the indication. Next, you see the bone or joint involved. Third one is the deformity. Which type of deformity, flexible or rigid deformity. Okay. And then we can use accordingly. And then now next choice is whether we should do classical or the modern variety. If it is a classical, that means there is a caliper, that is the double bar, that means aluminium bar, joint with boot or everything else. But if it is a modern variety, only the thermoplastic ankle foot orthosis is sufficient. If it is very cosmetic, that can be inserted even under the boot. Nobody will understand.
Sir, in recent paper, they have given like sensory feedback or like neuroprosthesis. So just few lines on.
Yeah, sensory feedback prosthesis is also coming. So in that case, there are some sensors are given on the sole. So if there is some pressure areas under the sole, that can be easily, you can get the feedback. In which areas the sensory feedback is coming more, which are less. We can adjust the pressure adjustment accordingly. This is very good prosthesis.
So sir, that one pain sensation also can be perceived with this one, sir.
Yeah.
With sensory feedback.
Definitely.
Okay. And is it available in our country, sir, right now?
No, not available in anywhere.
Okay, sir. And sir, regarding pylon prosthesis and one part which is called pylon in the prosthesis. So in examination also we have confusion in that. So
I've already shown it. Suppose there is a transtibial. Any prosthesis must have a shaft. It has a socket, it's some joint, it's a shaft. Suppose the below or tibial orthosis. The tibia is not there, so we have to substitute the tibia in that prosthetic design. So in that is the central stem is that actually known as the pylon. Central stem. So central stem maybe can be visible, and if you can wrap the outside with some cosmetic, that means it will look like almost a normal leg. So over the pylon, we can surround that pylon with the normal cosmetic area, cosmetic materials, so that it will almost looking like a normal leg. And the pylon is basically it connects the socket or the socket with the joint along with the ankle and the foot. Basically, the stem of the prosthesis.
And sir, how to take care of our orthosis or prosthesis? That one.
Yes, that
How
is the
to take care of that one.
Yes, that is the question asked in the examination. How to take care of? How to check it? How to check your prosthesis whether it is working well or not? That is the question is usually asked in the examination. So in that case, first of all, you have to check the prosthesis outside. Is there any outside that is crack? Is there is crack, or there's a nuts are loose, or there are some sharp areas developed? You have to see on the under surface, on the inner surface of the prosthesis socket. Suppose there is some excessive elevation or excessive depression or excessive ridges are there. So excessive worn out is there. Any part is excessively worn out. So in that case, we have to that means these areas are pressure areas that has to be taken care of. We have to actually mold it, or we have to give some pad over this. Okay. Now is the joint to see the joints. Joints should be freely mobile. If there is some defect, this is not freely mobile. So in that case, the joint should be checked and have to change it. You have to see the boot. There's some excessive wearing of the boot on the medial border or the lateral border. If it is excessive wearing on the medial border, that means that there is some boot is fitted on the externally rotated fashion. Or if it is a lateral border is much more worn, that means it is fitted on a more medially rotated fashion. Then the screw is tightened, it is a little bit abnormally fashion. So in that case, you have to correct it. So in this manner, you have to check this, and first check the prosthesis. Next, ask the patient to wear it and walk accordingly, stand, sit, walk accordingly. And just after doffing out, the removing, you have to check again the parts where it is used. It is redness, or is there, edema is there, there's any irritation is there, or coming pain is present or not. Usually redness and edema usually disappear, but if it persists, that means there is a excessive pressure inside that.
So essentially, you need to check the stump, the prosthesis, and the fitting.
Exactly.
All these three parts you need to check separately, whether the prosthesis is broken or worn out in one part or in good condition. Then you need to check the stump if there's a problem with it. And then you need to check the fitting of the socket with the stump, so that is a nice fit, so that there is no undue motion between the two. Okay, and there are different types of sockets depending on.
Do you have any ethical concern while prescribing the prosthesis? Any ethical concerns?
Any
ethical concern?
Technical.
Yes. Yes.
Any technical concern means the socket.
Ethical, sir.
Technical. Okay. Any technical concern?
No, sir. Not with the ethics, sir. Like when we are prescribing, like.
What is the ethical problem there?
Concern while prescribing. Do we have any like legally we are not doing anything wrong like that, sir? Because
I don't think there is ethical.
Unless you're getting paid for the prosthesis illegally, I don't think there should be any ethical issues. Okay. You're making money on the prosthesis, that might be an ethical issue. I don't see because you're giving it for amputees who need it. So I don't see what ethical issues can be there unless you're prescribing something that should not be prescribed.
And sir, you have explained regarding Steinbach brace and Danish Brown.
Yeah.
So do we have any advantage over this one, sir? You have explained everything, like,
Exactly.
but do we have in, or both we can prescribe?
Actually, Dennis Brown's plane, I already told, Dennis Brown's plane, that is a straight bar. The connecting bar is straight, and the rotation of the boot should not be more than 45 degrees. Previously, that opinion was done. But just after the knowledge of quantity has come, they have already understand the foot should be maintained at least 60 to 70-degree abduction. Not only that, in the foot abduction, also the Steinberg brace, the bar is little bit bent, so that both the limbs are little bit everted. So the limb is kept, the foot is kept everted, as also it maintained in 60 to 70-degree dorsiflexed. So that is the way. Now, not only that, there is another advantage. Because of this position, there is a sometimes in case of Dennis Brown's plane, there are some inside the boot. There is some the heel actually elevates from the level of the sole inside the boot. So that will lead to equinus deformity, even in spite of that. So in that case, so if we make it little bit everted and also the abducted, that possibility will become also prevented. So that is the most important. And another important point is once we rotated the boot 60 to 70 degree, that the posterior point of the both the heel should be the equal to the width of the shoulder. That is not actually appropriately not mentioned in case of Dennis Brown's plane also.
Sir, what is the concept of suction socket prosthesis?
Yeah. Now it is all most of the sockets are the suction socket. Previously, that was a different mechanical sockets was used, but now the suction socket is used, where the whole total contact is of the prosthetic socket is made with the amputated part of that limb. So initially there is some a silicon layer is given, silicon layer, and over this total socket is have a total contact on this. Basically over the bony areas like for the transtibial area, transtibial prosthesis, over the patellar tendons, and also the head of the fibula like this. Every area, every ups and downs of the amputated part of the limb should be covered, so that the area will become completely corrected, completely have a total contact. And below that there is some valve is there, and because of the valve, the air is actually pulled inside that from this socket area, and that will cause much more increasing contact on this socket wheels. Okay, there's a valve in this.
Yes.
So once the patient will use that limb during walking, the air is coming into the valve, and the valve actually removes that air. That is a one-way valve, and so that all areas are coming out from this socket. So ultimately, the total contactness is increased. That is the mechanism is used for this modern socket.
And sir, how it is advantageous?
Advantage is that basically that it becomes a part. That's a single piece that will becomes a single piece with this. That is basically the prosthesis that it acts as a third-class lever. So third-class lever. So all of you know, if it is third-class lever, if we increase the distant arm, that will become very much problem for the limb, because the muscle has to work more. So in that case, if it is a single piece, if it acts as a single piece, that is because of the total contact, socket and the limb becomes a single piece, that will help. It's a mechanical, that causes mechanical advantage for the third-class lever, isn't it?
Thank you.
So, sir, just one last question, sir, regarding one implantable prosthesis. They have asked, like, implantable, like
Implantable
the
prosthesis.
prosthesis, yes, sir.
That is the internal
the-
prosthesis. Internal prosthesis, like any hemiarthroplasty or total arthroplasty. These are the basically implantable prosthesis.
And
Mega prosthesis.
for the amputee also, sir, do we have any implantable prosthesis available for
Pardon?
the amputee? Like if it is a fixed
No, amputee is the
bone-
part is absent. How will you implant it? It is actually absolutely absent, na? So this is very difficult.
Okay, so there's a question about heel raise.
Yeah.
How do you calculate it?
Yeah, that is a very good question. That is heel raise. Basically, it is for the lower limb length discrepancy. Usually use the heel raise. Normally, according to the book, according to the theory, up to 1.25 centimeter shortening, no heel raise is used. Is it because it's not required, and the body is well adjusted with the help of the pelvis tilt. But if the limb length discrepancy exceeds half inch, that is 1.25 centimeter inch, So in that case, we have to correct it with some idea for under correction of 1 centimeter to 1.5 centimeter. Okay. Suppose there is a 3 centimeter shortening, limb length discrepancies. In that case, we have to use the heel raise by at least 1.5 centimeter. 1.5 centimeter. But the problem is, if it is more than 1.5 centimeter, heel is increased. So excessive body weight is borne by the tarsometatarsal joint. So in that case, if the heel raise is required more than 3 centimeter, so in that case, sole raise should be equally used. Sole raise should be equally used. So so up to 1.5 centimeter heel raise, no sole raise is required. So if the heel raise is required more than 1.5 centimeter, after every 1.5 centimeter heel raise, for every 1 centimeter heel raise, we have to use at least 50% of the sole raise. Do you understand my point? Up to 1.5 centimeter, sorry, heel raise is solely used. After 1.5 centimeter, if you use another 1.1 centimeter, that is 2.5 centimeter heel raise, so you have to use at least 2 centimeter or 1.5 centimeter sole raise. Otherwise, there is an excessive plantar flexion of the ankle. So in that case, excessive body weight is propagated from the heel to the tarsometatarsal region. That will cause forefoot pain. Okay.
Yeah,
Now another
so
important point: if there is more than 5 centimeter shortening, it is better to use the inner sole raise, not the outer sole raise. The boot has inner sole and outer sole. Because if you use the much more outer sole raise, the foot is become unsteady. There is a tendency to fall. That is why the lady who are using the pencil heel, they are very unsteady and they easily try to they will fall down. You understand? So if it more than 5 centimeter heel raise is required, so in that case, most of the half of the heel is used outside and half of the heel raise is used for inside, so that it is covered, and that causes stability during walking.
Yeah, and I think part of the reason for not using, sort of not getting it back to exactly the length as the opposite side depends on the stiffness of the knee and ankle. So if either the knee or stiff is ankle, then knee or ankle is stiff, then you need a shortening to clear the ground when you're walking. Okay, so that's why you don't go to the full length. If the ankle and knee are fully mobile, then it really doesn't matter. You can do the whole thing, but below a gap of at least 1 to 1.5 centimeters,
that will be better.
You don't really need it. Okay.
So, sir, it was very nice. Jaswinder sir has raised his hand. So, sir, if you have any question, please.
Yeah, sir. Good evening. I want to ask that, like in cerebral palsy, the flow reaction orthosis is used and recommended very commonly. And I don't have a very correct idea, but as much as I know, like for all kind of surgical corrections after equinus correction and with the hamstring release, most of the time FRO is advised. What is your advice on this, or what is your take?
No, for hamstring release, FRO is not used. FRO basically it acts as passive locking. It causes passive locking of the knee joint. Yeah. So passive locking is required when the quadriceps is paralyzed.
Quadriceps used in poliotics actually.
Yeah, polio.
This is where Dr. Sethi really did the work on it, is in poliotics.
Exactly.
You keep the foot in a bit of equinus in the prosthesis, and the bar in the front then pushes the knee back into extension so that the knee can lock when the patient walks. Okay.
Exactly. So for a polio with quadriceps paralysis, the FRO is used. Unilateral quadriceps paralysis, that is the most important. If it is a bilateral quadriceps paralysis, the FRO cannot be used. That is most important. Another contraindication is if there is an associated genu recurvatum deformity. So in that case, you cannot use this FRO. So in that case, we have to do some Lehen's modification of the FRO, where there is an additional upright is given in front of the thigh. So that will prevent the genu recurvatum deformity. Otherwise, there's another orthosis is already there. That is Swedish knee cage. Swedish knee cage can be used. That is very much cumbersome. That is why Professor Shetty this highlighted this to use this, because very light, it is very light. Even in spite of the knee is affected, we should not extend our orthosis above the knee. There's a below knee orthosis, the ankle foot orthosis, that in form of FRO is sufficient enough. So that will, as Professor John has highlighted, that is usually helps passive locking of the knee joint. That helps the function of the quadriceps. There is no importance in any other condition.
No, so in cerebral palsy, what is the indication to use it then?
In cerebral palsy, in which condition? Tell cerebral palsy, suppose it is a spastic cerebral palsy, basically, which muscles are involved? There are basically two joint muscles which crosses the two joints. For the lower limb, basically, there is a gastrocnemius. Suppose there is a gastrocnemius is involved, there is a toe gaze. Patient will walk on the toes. So do you understand? So in that case, what orthosis will you give? There is a tone inhibiting orthosis. Tone inhibiting orthosis. First of all, we advise the patient to give some plaster. We give some gradual stretching of the tendo, that is gastrocnemius. Once it is little bit corrected, and we fix it in the form of plaster and allow the patient to walk in this plaster. So this type of 3 or 4 plasters is done till the ankle becomes relatively dorsal, is neutral. Once that the joint is become neutral, then only we have to give some orthosis, which is almost equivalent to this FRO. That means we have to maintain just 10 to 15 degree plantar flexion, not more than that. But as there is a preferably there is a articulated FRO. So during the stance phase, so that will actually completely correct it. Once the patient will give some mid stance phase, that 10 to 15 degree plantar flexion will be completely corrected, and again that will reappear during the heel up toe off phase. Okay, and that 10 to 15 degree plantar flexion is required to lock the knee joint. That is why if there is a quadriceps paralysis is present in presence of the equinus deformity, that quadriceps paralysis, that equinus deformity should not be corrected. That because patient will walk with the help of this equinus deformity. You understand? That is the beneficial. So that is the reason why this type of prosthesis, there is 10 to 15 degree plantar flexion, the articulated FRO. This is not the plain FRO is used. The purpose is different. The articulated FRO, where it will help in 10 to 15 degree plantar flexion in the other phase of the cycle, but that will help to bring the ankle into neutral in case of during the mid stance phase in cerebral palsy.
Okay, so I think we should, if there are no questions, any further questions from the DNB students? Otherwise, I think it's already 7 o'clock, and I'm sure Dr. Pal has other things to do. But thank you very much for this excellent talk. I think you had to cover a lot of material there, and you were able to do that. Maybe we should have broken this into 2 talks. It might have been a little easier for people to assimilate what you have told them. But
thank you, John. I'm also enriched, so I'm also delighted to be being in front of this. And I shall be there if you invite me, and otherwise I can give in the panelist in other. This is a very good endeavor. It's a good endeavor to learn. Thank you.
Thank you so much.
And thank you, Janki. I think we should call it a day then. Okay, bye.
Thank you.
Bye, everybody.